Well, welcome everybody this morning. I hope you're all happy and safe and wearing your masks. You don't have to wear your mask at home. But welcome to our presentation this morning. We're so excited to do this because we didn't have to cancel. We could keep going because you're all doing it from your living room and your homes. I hope you received your letter. In the mail, you got your little puzzle piece to help us celebrate. This is our 35th year anniversary of the Baramedical Nurses Association. So there is the chat box. If you can see that, you can individual chat. You can send a message to Robin or to me, and we'll get those questions asked to the presenters at the end of their presentation. Hopefully we'll have time with each presentation. The order today, we're going to have Dr. Wong go first, and then Dr. Fernandez, and then a presentation by Deb Kritz and Mindy, sorry Mindy, can't say your last name, and Anthony Johnson, and then our fourth presentation will be by the Duke group with Kevin and Frank. I just wanted to tell everyone a little bit about the BNA. Obviously you all know since you're here, but it was started in June of 1985. There was a small group of nurses that realized that they were kind of a specialized group and needed the support of each other. So they got together and created the Baramedical Nurses Association. Their statement of goals and objectives is the same today because it's so important to us. It includes having our organizations supporting each other. We have our forum. Education was important on their mind, and obviously it's very important to us today. And then to have a public voice, and the more members that we can get to be part of our group, the more voice we can have in the hyperbaric society of the world, not just the United States. Now we have members all over the world, and we like to welcome some of them today if they're on with us. Thanks to the committee for working very, very hard. Dana, Terry, Kevin, Robin, and Deb, I appreciate all that you have done for today. And then I also wanted to thank the BNA board for the work that they do year after year, month after month. We have our monthly meetings, and they're just working hard all the time for you. Now, let's see, we're coming up with elections, so if you have any interest in helping us out, a few hours a month to help the BNA progress and do more things, that would be great. You can contact me or Deb Kritz. We also have an award that started a year ago, called the Shining Star Award. And I wanted to kind of highlight that today because there's a lot of members on. It's an award for someone who is new to hyperbarics, less than 5 years, and is really making a difference. So think about you, your fellow hyperbaric nurses, and let's get some people nominated for that award this year. Okay, thank you everyone for joining us. And Robin, I'll let you go ahead and let's see, Dr. Wong will take over and start his presentation. I'll have each of the presenters just kind of talk a little bit about themselves and where they work and what they're doing. Thanks, everybody.
Good morning. This is Enoch Wong. I hope everybody can hear me. I'm currently the medical director up in Portland, Oregon at Legacy Emmanuel Medical Center. I've been practicing hyperbaric medicine since '99, and I'm past president of the UHMS. And today I'm going to focus on talking about the effects of hyperbaric oxygen therapy on glucose homeostasis. And, this is something that is familiar to all of us as we practice hyperbaric medicine. And for the nurses, I think it's important because you're the ones that have to deal with this more so than the providers. Let's see. So I do have a financial relationship with Dexcom Incorporated. They are manufacturers of continuous glucose monitors, and we have done some research and are doing some research using their continuous glucose monitor. And so I do have research support, but no stocks or anything like that. So the goals and objectives for today, hopefully by the end of this talk, you'll be able to understand and explain why it's important to know how and if hyperbaric oxygen affects glucose homeostasis, to be able to talk about why we think it happens, and understand why we have protocols and how they came into existence. And then finally, we'll discuss some theories about the whys of why hyperbaric oxygen therapy and glucose may be tied together. So we'll start with just basic background. We know that hypoglycemia can cause seizures. We know that hyperoxia can cause seizures. But the management of hypoglycemia and hyperoxia seizures are quite different. And we also know out there's a very wide variety of management protocols for hypoglycemia related to hyperbaric oxygen therapy. A lot of these protocols focus on a minimum glucose level before starting hyperbaric oxygen, and then they all focus on supplementing with a high glycemic index carbohydrate source, which causes, unfortunately, a lot of iatrogenic hyperglycemia and poor glucose management. Our endocrinologists out there are trying to get our patients well controlled. They come in with a blood sugar of 100, they're happy, and we force feed them glucose. So we really need to understand if this is a smart thing to do, if we really need to be doing it. So this is not going to be as effective as a in-person lecture, but these are just questions to think about for the group here. How many of you have a protocol to address glycemic changes? I would say almost all of you. What is the minimum glucose level to go into the chamber? When I've given this talk before, I've had a range of responses from 100 to 150 to 180 even. What is your incidence of hypoglycemia or hyperglycemic events associated with hyperbaric oxygen therapy? What kind of glucometer do you use in your department, and how much do you know about it? This is something that was very educational in this process to kind of look at what we were using. And do you actually use your glucometers in the hyperbaric chamber for multi-place centers? And have you tested those thoroughly? And how confident are you in your opinion about the relationship between glucose and hyperbaric oxygen therapy? So just to briefly review about glucose homeostasis, we know that the blood glucose level triggers either a high or low response depending on the blood glucose level. If your glucose is high, your insulin gets stimulated, insulin release gets stimulated by the beta cells of the pancreas, and this then lowers your blood sugar. If your blood sugar is low, then your liver starts releasing glucagon, and this I'm getting some feedback there. Somebody may need to mute their speaker. The alpha cells of the pancreas release glucagon, which is then broken down into glucose. And so that's the basic cycle of hormone metabolism. There are more than just insulin glucose when it comes glucagon when it comes to glucose homeostasis, however, and I won't belabor the point, but here's just a table that shows all of the different enzymes at play here. So what happens when we eat? Well, if you eat something with high glycemic index carbohydrates, then you have a rapid rise in your blood sugar, and this is your junk foods or processed foods. Then you have your low glycemic index foods, and that has a much more muted response. And this takes about 15 to 30 minutes, as you can see, to peak here. When you take in glucose, then your insulin levels follow. And this is an important graph to remember, because a lot of times when somebody has a low blood sugar, you feed them something and then you say, well, how long do I need to wait to check their blood sugars? And if you only wait 5-10 minutes to check, you may not see such a high rise in their blood sugar. And then you give them another dose of carbohydrates, and then an hour later, they're really, really high. So you have to pace yourself when you are checking blood sugars to understand, hey, I don't need to check right away. I should wait a good 10-15 minutes before checking the blood sugar. So what happens in diabetes is that we have insulin resistance. Now, normal beta cell function allows you to manage the blood sugar with release of insulin. But if you have diabetes, your insulin becomes ineffective, and you end up with a relative insulin deficiency and hyperglycemia. And so, just as a refresher of diabetes pathophysiology there. So why do we think hyperbaric oxygen therapy affects glucose homeostasis? What is our clinical experience? And I'm sure all of you have had cases where you say, oh yes, this patient's blood sugar drops like a rock every time we put them in the chamber, and then some people don't. So what is there in the literature? Well, back in 1991 was the first abstract that I could find, and I'll just preface this whole talk by saying there's a lot of information on these slides, and I provided all the references below. This is more so that all of you have a reference that you can go back to if you find that this is something that interests you. I'm just going to highlight some of the more important information. I'm not going to spend a whole lot of time on a lot of these slides. So in 1991, Springer showed that there was an average drop of 51 milligrams per deciliter after hyperbaric treatment. That's 2 atmospheres for 90 minutes. 1996, another abstract came out that showed that patients who had diabetes had a 21 milligram per deciliter drop after hyperbaric oxygen therapy, but people without diabetes didn't really have a drop at all. Now, this is a small series of 18 patients, but once again, hyperbaric oxygen therapy is associated with a drop in blood sugar. In 2001, this paper came out that showed that patients without diabetes, here on the left, had no change in their blood sugar, whereas patients with diabetes had a 3.5 millimolar per liter, which you multiply millimoles per liter by 18, which is the molecular weight of glucose, to give your milligrams per deciliter. And this is important because sometimes you'll read papers that have millimoles, and sometimes it's milligrams per deciliter, but to convert, multiply by 18. All right, I was a chemistry major. If this explains some of my geeking out or focus on the chemistry here. But anyways, so this paper showed that patients with diabetes dropped by 63 milligrams per deciliter. In 2001, this paper came out, or this abstract came out, that showed that patients after one treatment had a drop of 17, after second treatment only a drop of 3, after treatment 3 minus 16, but after treatment 10, with each hyperbaric treatment, there's only 5 milligram rise in blood sugar. And this was the first paper that actually came out that showed that there was no major reduction in blood sugar. But interestingly enough, they did show that, let me see, between treatment 1 and treatment 10, there was a drop of 32 milligrams per deciliter prior to starting that 10th hyperbaric treatment. So this kind of raised the question whether or not hyperbaric oxygen was creating some kind of long-term control or improvement in blood sugar over time. 2002, another abstract came out that showed an average decline of 62.7 milligrams per deciliter. 2002, 2 millimoles or 36 milligrams per deciliter. And so you can see that there's a lot of papers out there that are showing a drop in blood sugar. Here's 52 milligrams per deciliter drop. Caroline Fife in 2007 published this abstract that compared 2 atmosphere treatments versus 2.4 or 2.5 atmosphere treatments. And what they did was they took out anybody that had an initial blood sugar less than 150 because they were fed. And so they're only looking at patients who were not fed prior to hyperbaric oxygen therapy. And when you compared 2 atmospheres versus 2.4, 2.5, the 2 atmosphere cohort decreased by 39 milligrams per deciliter. And the 2.4 and 2.5 cohort decreased by, I'm imagining that this is 47 milligrams per deciliter, but that's what was written in the abstract, was millimeters of mercury. So they concluded that your treatment pressure may have an effect on the magnitude of the decrease in blood glucose. Now, I'm going to remind you that treatment pressure also corresponds to your PO2, right? Because as you increase your treatment pressure, your inhaled PO2 will increase. So just keep that in mind because that's something that we're going to talk about in a little bit. 2007, another abstract that came out that showed that patients, while they were in the hyperbaric chamber, so this is intra-hyperbaric oxygen therapy, had a drop of 37 milligrams per deciliter, but after the hyperbaric treatment was over, it was only 17 milligrams per deciliter. And once again, this is somebody who's in the hyperbaric chamber getting oxygen, higher PO2, just like Caroline's data, 2.4 versus 2.0. So this is suggesting that maybe people are getting some kind of oxygen effect as opposed to perhaps just the hyperbaric treatment by itself. The most recent data, 2019, this was a report that patients receiving hyperbaric oxygen therapy had a median decrease of 25 milligrams per deciliter, but notably no patients had any side effects or required any emergency care. And they found that this happened more often in patients with type 2 diabetes than patients in type 1 diabetes. So if you were to summarize all of the evidence so far, you see that there's quite a lot of reports. Unfortunately, 1, 2, 3, 4, 5, 6, 7 are in abstract form only, and 3 were published. So this is something that is not readily known in the literature unless you're doing searches through Rubicon, or you're just kind of data mining through references in other papers. But only one of these showed that there was no decrease in blood glucose. Now, when you take a look at patients without diabetes, there's only been 2 that reported any data. One has number associated with it, and the other just basically says no change. So very few papers have been published talking about what happens with hyperbaric oxygen therapy for patients without diabetes. All right, so we all now have an idea. Hyperbaric oxygen can affect your blood sugar. Well, how do we protect ourselves against it? And that's where hypoglycemia protocols have come into play. The first mention of a protocol was in 1994 when this group measured blood glucose drops or hypoglycemia, and they defined this as significant hypoglycemia requiring intervention. Now, because this is an abstract, there was not a lot of detail into what that intervention was. Was it just a blood sugar number that was low, or was this somebody who was symptomatic and required some kind of bolus? And so this protocol evaluated multiple aspects of the protocol. So they had the risk screening portion, they had diabetic teaching, they monitored blood sugars daily and close follow-up. And they dropped from 1.3 events per 100 treatments, or 1.3%, to only 0.16. So it went from 1.3 down to 1.16 in terms of their incidence. So this was a fairly significant improvement or decrease in hypoglycemic events. In 1998, another abstract showed that using a protocol where patients under 150 were fed, the drop in blood sugar only occurred in 26.4% of all patients, despite feeding, or I should say, despite feeding, still there was 26.4% of patients saw a drop in blood sugar below 100. But when you look at the percent of treatments, it's 1.92, so 26% in patients, but only 1.9% of total treatments. In 2015, the Mayo Group did some work looking at their patients who had received hyperbaric oxygen therapy, and they provided better definitions here as to what they were looking at. And so when we look at our patients, unfortunately, a lot of times, all we're looking at is the blood glucose number. You know, the finger stick comes back 70 or 80 or 90, and we automatically jump on it. But it doesn't reflect the fact that some patients are not symptomatic, right? And so the first level of hypoglycemia was just a number less than 70. The next level was symptomatic hypoglycemia, and the third was severe hypoglycemia, where another person was required to actually administer the carbohydrates to that patient. So they defined different levels of hypoglycemia, and when they looked at 3,000 or so hyperbaric sessions in 190 patients, they found that the incidence of hypoglycemia, so this is just the number, during or immediately after hyperbaric oxygen therapy was 1.5% of sessions. It was higher in patients with type 1 diabetes compared to type 2 diabetes. But symptomatic hypoglycemia, once again, this is just not the number itself, but somebody who is showing symptoms, was only 0.19%, and no patients were in that severe hypoglycemia where they required assistance to take glucose. So our incidence of severe symptomatic hypoglycemia is actually not as high as perhaps people were thinking when you only look at the number as your definition of hypoglycemia, right? We always say, treat the patient, not the number. They found that looking at their data, a pre-hyperbaric oxygen glucose of 150 milligrams per deciliter best predicted the risk of subsequent hypoglycemia. And once again, they showed that type 1 diabetes was more associated with hypoglycemia than type 2. And why did they do this? Well, they did this as part of their performance improvement project. And if anybody wants to read a good model for how to do a quality improvement project in hyperbaric medicine, then this paper is one to look at. They needed to do that retrospective analysis to come up with their protocol to say, all right, what number do we feel safe with going into the chamber? And so based on that, their number of 150 comes into play here. So they changed to a protocol where if you had over 150 milligrams per deciliter, you didn't do anything until somebody became symptomatic. Between 111 and 149, you checked their blood sugar 30 minutes after reaching the bottom. Now, obviously, this doesn't apply to monoplace chambers. Between 70 to 110, you gave 15 grams of carbs, and then you checked 30 minutes after reaching bottom. And if they started under 70, then you consulted the doc and discontinued their hyperbaric protocol. And during this quality improvement project, they were able to reduce the number of glucose checks they did by 37%. They had much better improvement in compliance with their protocol, and they only had 5 recorded hypoglycemic events, but they all occurred prior to or in the run-in period to starting their protocol, but none after they started their protocol. The most recent abstract or paper talking about protocols was this 2017 analysis of about 1,000 patients, 1,000 treatments rather. They fed all patients with blood sugars less than 120. They found that the mean drop after hyperbaric oxygen therapy was 12.7 using their protocol, and 10% of treatments had a blood sugar less than 100. Now, keep in mind, their definition now of low blood sugar is 100 as opposed to the Mayo protocol of 70. So you have to look at some of these research protocols and decide, all right, what numbers are you going to use? So when you look at all of the protocols that have been reported in the literature, you have numbers that are not reported in terms of when do you feed them, then 120, 110, 120. I know our department uses a blood glucose level of 100 in our protocols, and I know that there are a lot of numbers that are out there depending on which center you're practicing at. All right, so we've talked about the reasons why we want to look at blood sugars dropping in hyperbarics. We've talked about what people are doing to prevent blood sugars from dropping. But you really, and this is something I didn't really look at closely until I investigated this question, which is how do we test for blood sugars? You know, like how do the tests work, and can we rely on the tests that we are looking at? So the type of blood or the source of the blood is a lot more important than you might think. So whole blood values, blood sugars, are about 10 to 15% lower than plasma values. So if you look over here, venous whole blood, this is the blood sugar levels. This is with using a oral glucose tolerance test. If you check the whole blood versus checking capillary whole blood, you have a difference of 10 to 15%. And capillary blood is still different than venous blood. So if you look at venous whole blood here, there's a 11% difference between venous whole blood and venous plasma. and then another 3% difference between capillary plasma and venous plasma. Capillary whole blood and capillary plasma also has a difference. So the source of your blood becomes important when you start looking at these papers and you start looking at different studies and how they're sampling blood. And we all know that you're supposed to have a fasting blood sugar. And why is that important? Well, if you're testing fasting levels, fasting glucose concentrations, then they're virtually indistinguishable, whether you're testing arterial blood, capillary blood, venous blood, it doesn't matter. That's why a fasting blood sample is always the most accurate. A postprandial value changes significantly. Your arterial value may differ from your venous values by 20 to 70% because of eating. And we know that a fingertip capillary sample is 15 milligrams per deciliter greater than an antecubital venous sample 45 minutes after eating. So always appreciate when your patients have eaten and to see whether or not you're sampling at the same time if you're looking at blood studies and how their methodology changes. Now, this part of the talk is going to get a little bit more technical, and I hope you bear with me. I think being the first talk of the day, maybe you won't fall asleep quite as quickly, but I'll try to make this as relevant as possible. You need to know how your glucometer works, and there are multiple ways. The first is the hexokinase method, and this is a colorimetric test where a change in the color of the solution affects the result. And versus an enzymatic system, you have glucose oxidase reactions, glucose dehydrogenase reactions. A lot of these tests use what's called an amperometric reaction, where the chemistry that is happening creates an electric charge, and that electric charge creates a current that then drives your meter to give you a reading. And then once again, the colorimetric. And so this is for laboratory-based glucometers. So this is the central lab in your hospital may have a test that uses any one of these. And here's some models. And I bet you 99% of you probably don't know what kind of glucometer your lab uses, but it may be something to look at. It's not quite as relevant as knowing the details of your home-based glucometer. So this is what you're probably using in the clinic, is a home glucometer, maybe hospital-based, but it's still the same kind of design. So with home-based glucometers, you have basically two kinds: non-continuous or continuous glucose monitoring. So the first is the tried and true, the point-of-care glucometer that we look at, that measures capillary blood. You do a finger stick, you puncture the skin, and you get capillary blood here. The blood gets dropped onto a test strip. It usually has multiple electrodes with an enzyme that's impregnated on the test strip, and it's usually a glucose oxidase enzyme or a glucose dehydrogenase enzyme, and this causes a current that is changed to a voltage, to a reading, and that gives you your number, right? The problems with this is that it's painful. Patients may not do it, and if the test strips are not stored properly, they may not be accurate. The continuous glucose monitor, which is becoming more and more prevalent now, is perhaps the wave of the future, where you have a transmitter or a sensor that is inserted into the skin, usually on the abdomen or on the back of the arm. This is connected to a transmitter, and then this transmitter uses a Bluetooth or near range signal transmitter to a receiver, and that gives you your number. Now, this system gives feedback every 5 minutes, and so you can get a continuous, essentially, tracing of your blood sugar over time. Now, the limitations to this is that some of these models, now there are multiple brands out there, there are multiples, some of these require calibration with a finger stick. Some don't, but if you do need to calibrate the glucometer with a finger stick, then you're stuck still sticking yourself twice a day, which kind of defeats, I think, some of the advantages of the continuous glucose monitor. Okay, so here's the chemistry part, and I'm going to simplify this as much as possible, but the hexokinase reaction is the one that is most often used in laboratories. So it's not generally used at home, but this is why the lab has a much more accurate blood sugar machine reading than the point of care ones. It has higher accuracy, but you can't really use it on test strips, and that's why it's only used in the lab. So what happens is glucose is converted to glucose 6-phosphatase, G6P, using hexokinase. That's the enzyme there. That generates your ADP. Hexokinase then breaks G6-phosphate down to 6-phosphogluconate, which you're not measuring the 6-phosphogluconate, you're measuring NADH. So NAD gets reduced to NADH, and this can be detected on a photospectrometer. And so at 340 nanometers, your machine then measures this peak or trough, as it were, and to say, all right, what level of glucose do we have in this sample, right? So hexokinase is a waveform analysis. It isn't reliant on oxygen at all. There's no oxygen in this reaction. So it should be independent of oxygen levels, right? As opposed to glucose oxidase, which is an enzyme that is used on test strips because it's stable. And this is the crux of the problem, or the crux of this talk. So if you're trying to pay attention, I once again will try and simplify this. Glucose, it's converted to gluconic acid by glucose oxidase. This takes water and oxygen, converts it to hydrogen peroxide, and then in the process of converting hydrogen peroxide back to oxygen and water, it releases electrons, and this is then converted into electric signal, right? So if you look over here at these reactions, you don't really need to worry too much about the chemistry other than to look at this next slide, next highlighted here. So this basically shows that there is a competing reaction, right? These two right here, where glucose oxidase plus oxygen, so high oxygen levels, will steal some of this product. And essentially, those two reactions insert themselves here. They take electrons away, decreasing the amount of electrons available for the glucometer. And so high oxygen levels cause the glucometer to read low because the electrodes are not seeing as many electrons as they normally would, all right? And so the idea, and once again, the crux of this argument and the take-home point from this slide is that in a high oxygen environment, if you use a glucometer that uses glucose oxidase, you may get lower numbers than are truly there. All right, that's the take-home there. And high oxygen levels can be accomplished, obviously, by breathing oxygen. You can increase it going from 0.21 to 1. But once again, and this is our basic hyperbaric oxygen physiology, if you increase the treatment pressure, then you're really jacking up your PO2, and you are getting the Dalton's law effect, and you can really depress glucose levels using a glucose oxidase reaction glucometer. Compare this to a glucose dehydrogenase enzyme-based glucometer. There is no oxygen in this chemistry here, so it is less prone to interference by exogenous substances or by blood oxygen, right? So if you have a glucometer that uses glucose dehydrogenase, you will not artificially lower your blood glucose levels because of breathing oxygen. So at this point, I would just ask yourself, do you know what kind of chemistry your glucometer uses? And if you don't, I would suggest that it's important to find out what the chemistry is on your test strips. In talking about glucometers and learning about glucometers, there is something called the MARD, the mean absolute relative difference. And this is a way of testing glucometers to see how accurate they are. And the take-home message here is that a smaller number means that you have a more accurate measurement, and a larger number means you have more inaccurate measurements. And the glucometer companies also use surveillance error grid to measure their blood sugars versus a laboratory to see how accurate they are. So if you see a grid that's got most of their numbers here in the green, it's a more accurate glucometer than one that has a lot of scatter. That is probably more than you need to know, but when you look at papers or anything that are assessing accuracies of glucometers, you'll see these terms, and so I just wanted to throw that in there. So here's just a question for the group. What do you think the FDA and laboratory standards are for the acceptable error for a point of care glucometer? You know, like if you were to do 100 tests, what percent error would be acceptable? And the number may surprise you. Some may say 5% because you want to make sure that that glucometer is accurate, right? But in reality, as of 2013, which is the most recent report, the lab standards are that for blood sugars over 100 milligrams per deciliter, the standard is 95% of the results should be within 12 plus or minus 12.5%. And for blood sugars over 75, 98% should be plus or minus 20%. So this is a huge amount of error that's allowed within your blood sugars. And if you look at the milligram per deciliter, it's plus or minus 12 milligrams per deciliter, and below 75, it has to be within plus or minus 15. So a reading of 70 on your glucometer could be as low as 55 or as high as 85. And so that's not quite as accurate as I would have hoped. And if you look at the FDA's guidance, this is the 2018 executive summary, they state that 95% of value should be within 12% for blood sugars over 75 and within 12 milligrams per deciliter less than 75. So it's basically the same numbers that were used in that last thing. But reportedly, the number one complaint the FDA gets in terms of devices is for glucometers and inaccuracy of glucometers leading to inappropriate medical decision making. So you have to wonder, how accurate is your ruler? You know, like we all depend on our glucometer for deciding whether a patient is at risk of low blood sugar or not. Number one, how accurate is the measurement, the glucometer itself? And then how much do you believe your glucometer, depending on if you're using it with a high oxygen content or not? So if you look at the literature, there are a few papers that are out there that talked about chemistry, the chemical strips. And so in 1987, this paper showed that blood sugar levels were elevated in the hyperbaric environment, and this persisted even if you transferred the sample out of the chamber and tested outside of the chamber. And what we do in the multiplace chambers is we lock our blood out and we test on the outside. Some people may have their glucometers inside the chamber, but that's going to be even more susceptible to a high oxygen content. In 1991, there was this study that compared 4 different glucometers, and here are the brand names here, and they looked at a single hyperbaric exposure to 2.4 versus 60 consecutive sessions, and compared that to sea level pressure. And without boring you with the details here, here's the sea level here, and then the one exposure with hyperbaric medicine, and then multiple hyperbaric oxygen treatments, and for each different glucometer. And it was kind of all over the place. 2 using lower controls. 2 had higher readings, 1 had lower readings, and 1 had no change with hyperbaric oxygen therapy. Using a high value control, 3 were higher and 1 was lower. And so there were some theories about, once again, the chemistry that was being used by those glucometers. Now, those glucometers are no longer actually being manufactured, and you have other glucometers now. So you have to kind of look at the message there, which is that glucometers may not be accurate under hyperbaric conditions. And here's another test in 95 using glucometers in the hyperbaric chamber. This time they compared one glucometer that was using a glucose dehydrogenase reaction, which shouldn't have any effect with high oxygen levels. And they tested multiple iterations and different blood samples with different concentrations from low to high. And once again, this is a very busy slide, but to help you understand it, this is testing at 25, 50, 100 to 250 milligrams per deciliter, so low to high, and then looking at 1 atmosphere versus 2.4 atmospheres. And you can see this line here tells you the number that's important, that all glucometers showed a decrease at 2.36. So this was a 20-point drop, 6-point drop, 12-point drop, 15-point drop. All of them had variability, and all of them, including the glucose dehydrogenase one, which is the HemoQ right here, all of them had a drop with the hyperbaric oxygen treatments, doing that in the hyperbaric chamber. Now, the one thing that was noted was that the glucose dehydrogenase HemoQ here had a decrease to the response rate to manual input, meaning that they couldn't get the machine to work right in the hyperbaric chamber, and they think that this is because of the physical pressure changes causing the unit to malfunction. Bottom line is, this once again shows that if you're measuring blood sugars in the hyperbaric chamber under hyperoxic conditions, the blood sugar drops. There's other tests. Here's some just more tests that showed it. There is one glucometer, the SureStep Pro, that was tested and compared against the YSI. The Yellow Springs instrument is a laboratory computer, so this laboratory analyzer, and this showed a good correlation between the SSP, the SureStep Pro, and the YSI. That states that yes, even in a hyperbaric chamber, we were able to get accurate measurements. And you compare that to the bedside glucometer that they were using, and it was not on the same line as the laboratory value. And so unless you're doing this kind of testing with all your glucometers to say, all right, this is okay to use in the hyperbaric chamber or not okay to use in the hyperbaric chamber, you have to question whether or not the readings you are getting are accurate or not. And one thing that also comes into play, and people may not realize this, is that if you draw a blood sample and you let it sit, the plasma glucose decreases over time as the white blood cells and red blood cells metabolize that oxygen. And so what you need to do is you need to stabilize the blood sample by putting it in sodium fluoride to preserve the blood glucose level. So if you're ever planning on doing a study and you want to collect blood samples, you have to make sure that your blood tubes are stabilized. All right, so the question is, does it matter if you're taking a blood sample in the chamber or a blood sample out of the chamber? Well, we know that in clinical studies, your blood PO2 drops quickly when exposed to air. When you do blood gases, right, your blood gases are all airtight. You put that little cap on there and you don't have any air bubbles, and that's to preserve the blood in a anaerobic state, or as anaerobic as you can get, and you want to test it quickly. Because we're testing the blood so soon after removal from the hyperbaric chamber, I think that it's generally considered to be accurate. So you don't necessarily need to worry about that, about the drop in PO2, but realize that if you test under pressure in the chamber, you will be at the highest level of PO2 that's out there. So we'll go back to that original table where we looked at the drop in blood sugar from all of those abstracts and papers. We say, well, there's a preponderance of evidence that shows that blood sugar drops because of hyperbaric oxygen therapy. Only these three in green actually report a glucometer that is free of oxygen effects. All of these are either unspecified or they are a glucometer that can be artificially lowered by high oxygen content. So then this calls into question just how robust our body of knowledge that says, hey, you know, blood sugars drop because of hyperbaric oxygen therapy. You know, does it really drop, or is it the test that we're using is inaccurate and falsely low? Now, I'm not saying that it is the reason, and I'm not saying that we don't get a drop, but I'm just saying this calls into question how much we trust these numbers. So this brings us to continuous glucose monitoring. This measures interstitial fluid, not blood. So we don't need to do blood draws or finger sticks. There may be a little bit of a lag time versus the blood glucose, but because we're measuring every 5 minutes, you get a global picture of their blood sugars. And you have to say now, well, can we use this in the hyperbaric environment? And if we do use it in the hyperbaric environment, is it accurate? And so in 2012, there was a paper where they used a single subject, and I don't know how they convinced the person to do this. It must have been a fellow or a junior faculty member, but they inserted 48 sensors onto this one person. 24 on day 1 on the right side of the back and abdomen, and 24 on day 2 on the left side of the back or the abdomen. So, you know, I just can't even imagine what that guy looked like. But they tested both in hypobaric environments and hyperbaric environments, and found that everything worked in the hyperbaric environment, but in the hypobaric environment, only 79% of the sensors worked. And they think that this was a firmware issue. And they corrected that to the hyperbaric environment. Regardless, what they found was that the MARD, once again, a low, right? So the MARD was lower for the hyperbaric test, meaning it was more accurate for the hyperbaric test than the hypobaric test. And they theorized that there may be microbubbles that are caused during the insertion of that sensor wire into the body. And in a hypobaric environment, those bubbles increased in size because of Boyle's law, causing reduced contact between the wire and the fluid, resulting in decreased accuracy. Now, all of that will go away in a hyperbaric environment because all those bubbles will decrease in size, if that's the true reason. So what we did is that we partnered with Dexcom because our safety director, Shay Bliss, was just really fascinated with this and really pushed, and we said, okay, let's contact them, and if they want to play, then we'll play with them. And sure enough, they were very interested, and we conducted some tests. First of all, we wanted to say, is this safe for hyperbaric use? Right, and so we followed the guidelines laid out by Francois Berman in a paper several years ago about safety evaluation. So we did our safety evaluation, and it uses a 3-volt lithium manganese dioxide button battery, which, you know, we know lithium is a big no-no in terms of batteries, but the battery and the circuit board are completely enclosed in epoxy. So there's no contact with air at all in the manufacturing process. So what they do is they take these molds. So this is the transmitter that has the battery in it. This is the sensor wire that comes out. This is what's stuck to the skin. And what they did was they put the battery and circuit board in epoxy, pressurized it to 90 psi, which is greater than 6 ATA, 90 psi for 72 hours during the manufacturing process to remove any air spaces inside the plastic. And then they submerged it underwater up to a depth of 8 feet for 24 hours to make sure there was no electric discharge. So we were pretty satisfied that this was safe because there would be no electric discharge at all. And then what we did was we tested to see whether or not this would be accurate. We put them on these, what they call them walkabouts. They're simulators that would simulate a low, normal, or high glucose. And this is the low, normal, and high glucose. And we found no errors in the readings. And we put these transmitters in the hyperbaric chamber on the far side of our hyperbaric chamber. These receivers were placed outside of the hyperbaric chamber. And because of Bluetooth connectivity, you know, so the transmitters are there. And this was a distance of 10 feet through the hull. We were able to receive the data. So this showed no errors in the readings. And then we sent everything back to the manufacturer, and they did X-ray analysis, and using microcalipers showed that there was no swelling of the battery, there was no change in voltage, there were no voltage spikes, and you can see here that everything is encased in this epoxy. And so based on this, and this is published in the UHM journal, I think the most recent one actually, showing our methodology for testing and clearing that. So once we did that, we said, all right, well, let's put this on patients. And we took volunteers who actually did not have diabetes. And what we did was we placed the monitors on them, and we kept them NPO for the 2 hours prior to hyperbaric oxygen therapy. And we wanted to see, all right, are you going to have any change in your glucose readings with a hyperbaric treatment? And we compared it to the current glucometer we used in our clinic, which was a glucose oxidase glucometer. And then we compared it to the Contour point of care glucometer, which is a glucose dehydrogenase glucometer. And we chose patients who did not have diabetes because we didn't want drops in blood sugar occurring because of their diabetes. We wanted to know whether it was the hyperbaric treatment itself that was causing any problems. And so this is our standard treatment to 2.4. We did measures 30 minutes, 15 minutes, and right before the door closed, we did a measurement right at the time we reached pressure before oxygen. We did 15 minutes into the oxygen period, 30 minutes into the oxygen period, and then we repeated. And then we did as soon as the door opened, and then for 15 and 30 minutes after that. And this was our data. And you can see this is the run-in period before the chamber. This is the chamber period, and then the post-chamber period. And we got data on, well, we enrolled 26 subjects. We excluded 3. Subject 1 never actually got their hyperbaric exposure, so they were replaced. Subject 9, for some reason, we weren't getting any data at that time. And the TCOM data, oh, this is the other thing that we did. We measured TCOM within 3 centimeters of the continuous glucose monitor. And that was done to demonstrate that we were seeing high tissue oxygen. And this TCOM lead got loose, and I think on this one, they forgot to put the contact fluid in, and so we weren't getting any measurements at all other than measuring chamber air. And so with all that, we did get some results, and we showed that, so if you look here, here's the Dexcom, here's the Novostat, which is the glucose dehydrogenase, right? So this is the, glucose oxidase. This is the glucose dehydrogenase. There we go. I just learned how to use this laser, this pen during presentation, so I apologize if I'm overdoing it. But anyways, when you look at it, we're comparing normobaric air to hyperbaric oxygen, right? And when you look at the comparison between normobaric air and hyperbaric air, there was only one glucometer that showed a significant change, and that was the Dexcom. And that actually showed an increase of 2.6 milligrams per deciliter, which is really irrelevant clinically, but statistically speaking, it increased. The Novostat and the Contour didn't have any change in the glucose readings. But when you look at the comparison between hyperbaric air and hyperbaric oxygen, the Novostat had a drop of 8 milligrams per deciliter, or 9%. And when you look at hyperbaric oxygen versus normobaric air, this is what we're mostly concerned about. You saw that the Dexcom had a statistically significant increase of 3.7 milligrams per deciliter, and the Novostat, which is our glucose oxidase reaction, had a drop of 10.4 milligrams per deciliter. The glucose dehydrogenase glucometer that shouldn't be affected by oxygen had less than 1%, or had 1.12, or just over 1% drop, which was not statistically significant, which goes along with our thinking that the glucose dehydrogenase reaction will not be affected by high oxygen. And we confirm that when we look at when we compare the continuous glucose monitor versus point of care glucometer, this is the Dexcom on the left on all 3. So this is breathing air, this is breathing hyperbaric air, and this is breathing hyperbaric oxygen. So if you look at those 3, the Dexcom was consistently higher than either the glucose oxidase or the glucose dehydrogenase glucometer. And I can't really explain why that is, other than, that's just the numbers that we got. And even with that being said, though, I think that it didn't really change significantly. When you look at the glucose dehydrogenase glucometer, which is the one on the right in all of these three, that's the contour, and you compared it to the other two, we showed that the other two changed, whereas the glucose dehydrogenase one didn't. And that was just another way of looking at the data. So our findings showed that the continuous glucose monitor functioned reasonably well in the hyperbaric oxygen environment. To keep in mind, statistical significance doesn't equal clinical significance. We showed it statistically increased by 3.7 milligrams per deciliter, but that doesn't really make a whole lot of difference. We didn't test other continuous glucose monitors, and the results may not be the same in patients who have diabetes, right? We are actually planning on testing a cohort of patients with diabetes. We're just about to start that study, but with everything going on, we decided to hold off on actually enrolling anybody. A lot of people have asked us whether or not you can use it in monoplace chambers. We haven't actually tested it in a monoplace chamber, but from all of our studies that we've done of the safety evaluation, I would have no concern about using it in a monoplace chamber. And this allows us to do things that we haven't been able to do before, which is to monitor a patient's blood sugar in the hyperbaric chamber, in the monoplace chamber, while they're getting their treatment, right? So one thing, and this is just an aside as to why we might be seeing this increase in the Dexcom, the continuous glucose monitor. Why are we seeing an increase in the blood sugar when it shouldn't be changing? Well, we tested, and this was a lot of fun. This is what happens when you spend a week in South Korea with Steve Thom and ask him all sorts of questions, and he gives you ideas of how to test your theories. We took a bag of saline and created a glucose solution, and then we inserted all of these continuous glucose monitors onto the bag of saline, and we're measuring them. We then exposed this bag of saline, this glucose solution, to air for 30 minutes. We mixed oxygen by bubbling oxygen into the solution for 30 minutes. We put a Foley catheter with a temperature probe into the chamber, and we could get a temperature reading on our cardiac monitor, and then we tested it at various pressures. We went all the way to 6 atmospheres absolute, and we took measurements of their estimated oxygen using mathematical modeling, their temperature, and then the reading from their glucose meter. And what we found was that as you pressurized the chamber, you had a rise in the glucose. And so you would say, well, is this because we're changing the chemistry, or is something else going on? And why was there this drop as we were bubbling oxygen through? And then we looked at the temperature readings, and we saw that the temperature dropped and rose as we were bubbling oxygen through. That was lowering the temperature in that bag of saline. And when you correct for the temperature and you plot it out, it's much more linear. So we think that maybe the glucose estimate that was rising in that glucometer for the Dexcom had to do with changes in temperature as opposed to changes in pressure. Anyways, that's a little aside just to show that we were geeking out and playing with our hyperbaric chamber and doing some experiments there. So our conclusion was that there is a statistically significant effect of gas condition on glucose estimate with a rise of 3.7 milligrams per deciliter, and there was a drop with our glucose oxidase glucometer. In the interest of time, I'm going to skip this last section. There are various theories. Well, I'll be very brief, I should say. I'm not going to skip it entirely. But there are theories on why we have glucose homeostasis, effects of hyperbarics. One is that it supersaturates plasma and drives glucose consumption. We're just ramping up that engine, revving it up and using up our glucose. Others is that it stimulates insulin secretion. Another theory is that it increases your sensitivity to insulin. It might act on anti-insulin hormones, or, and this is stuff that we're looking at, maybe it's the natural effect of being NPO in a hyperbaric chamber for 2 hours, and that's why patients drop their glucose. And the final thing that was raised in my testing is that maybe it's an artifact of the testing algorithms and the fact that we're using glucose oxidase glucometers, and we're not really seeing a drop, but the number is just artificially low, right? And so the next several slides go through various tests. I'll just cut to the chase. We don't think that it's a drop in, or we don't think that we're ramping up glucose metabolism, because it doesn't drop in it doesn't drop in control patients. If we were really ramping up glucose metabolism, it would ramp up glucose metabolism in everybody, not just in patients with diabetes. And so we think it's not causing a rise in glucose metabolism. Is it increased insulin secretion? Well, several studies have looked at insulin levels, and you can see here in patients with diabetes, the insulin levels actually go down. In patients without diabetes, there's no change, so we're not affecting insulin secretion. Is it insulin sensitivity? And a group has been using this hyperinsulinemic euglycemic clamp, basically a way to test for insulin sensitivity, and showed that not only was it that basically, yes, we were increasing insulin sensitivity, and it was happening in patients without diabetes as well as in patients with diabetes. So hyperbaric oxygen increased insulin sensitivity in overweight males, both with and without type 2 diabetes. There are no studies that are looking at anti-insulin hormones, and so that's a thing that we can be testing, but it's very difficult, I'm finding out, to actually do these tests, and these tests are not very sensitive or specific. Is this a natural drop in glucose over time? This is something we're testing. We're going to be taking patients and having them sit in an exam room for 2 hours while we measure their blood sugar, and then the next day we're going to have them sit in a hyperbaric chamber getting a treatment, and we're going to compare the relative drop on their control day versus their non-control day. And we're going to take a look at our continuous glucose monitor, as well as a glucose monitor that uses, once again, a glucose oxidase and a glucometer that uses glucose dehydrogenase. So in conclusion, we know that there's a drop in blood glucose between 20 to 60 milligrams per deciliter as a result of hyperbaric oxygen in all but one abstract that's been reported. There's no drop in blood glucose in patients without diabetes, and that one abstract showed a decrease in pre-hyperbaric oxygen glucose from treatment 1 to treatment 10. So this goes along with that increased insulin sensitivity argument. Testing protocols in most publications were not discussed, so we don't know how accurate the tests are, whether or not we're seeing an underestimation in glucose value. We know that hexokinase and glucose dehydrogenase reactions are not affected by HyPO2, but unless you know what kind of chemistry your glucometer is using, it's not necessarily going to help you. We know that continuous glucose monitoring shows a statistically significant rise in glucose values, but that's not really clinically relevant. As far as testing protocols, we have a variety of testing protocols out there, but I'm afraid that liberal feeding with high glycemic index carbs may cause this iatrogenic hyperglycemia. And we also know that there's actually a very low incidence of symptomatic hypoglycemia, that we are just chasing numbers a lot of times. And in terms of the mechanisms, the only mechanisms that's been proven, I think, is this increase in insulin sensitivity as a result of hyperbaric oxygen therapy. So in our future, I think that we need to decide if we're going to continue to study this. What is a clinically relevant number? What are our parameters that we need to use so that we're all measuring the same thing? And I think we may be looking at using continuous glucose monitoring to reduce finger sticks, to get better compliance, and to really assess our patients in the monoplace environment. And if all goes according to my plan, we'll be able to answer the question for sure whether or not we have a true effect on blood sugar based on hyperbaric oxygen therapy from a individual treatment perspective, not a over 10 treatments. But are we really worried that a single hyperbaric treatment is going to drop your blood sugar, or is this a result of being in the hyperbaric chamber for 2 hours? So what I would recommend based off my research is find out what algorithm your glucometer in your facility is, develop a practice-based algorithm and be consistent in using it, and consider individual exceptions to the rule. I mean, we have patients who say, I have diabetes, yes, but I don't take insulin. I don't, it's well controlled. Do you really need to poke my finger twice a day for every hyperbaric treatments? And we've developed some workarounds around that. So if you have any questions, I know that I went a little bit long. You can send me an email, and I'm happy to answer questions if there are any questions, if you have time for questions, I should say.
Thank you so much. That was amazing. I had a couple of questions that came through. I think you kind of touched a little bit on this after the question was asked, but how long after treatment would you, I'm taking the person out of the chamber, would you think that the glucose test is not affected or is accurate and affected by the hyperoxemia?
Well, we know that blood PO2 drops pretty quickly after you exit the chamber, but subcutaneous tissue and muscle takes hours to drop. So I would imagine that if you're taking a capillary sample, that PO2 is going to be elevated for some time because you're going to be off-gassing oxygen. So this is where we're not sure. And that's why, if we can use the continuous glucose monitor and show that, hey, it doesn't change over time while you're in the chamber or after you've left the chamber, then do we really need to check that blood sugar? Or, is the fact that we're always getting a low blood sugar after they exit the hyperbaric chamber solely because they have a high oxygen content and now your glucometer is low? Now, if you use a glucose dehydrogenase glucometer, then you can check anytime and it shouldn't be affected.
Okay, thank you. The second question was kind of what you said right at the end. How it's kind of like type 1, type 2, patients that are just on metformin. How do we differentiate between who's really, obviously type 1s are going to be affected probably a lot more than type 2s, but whether there's a lot of patients that come in on metformin, and it kind of sounds right there at the end that you've kind of got a workaround. You don't test everyone.
Right. So what we've done is not validated by any study or anything like that. But what we've done is like, all right, we're going to check your blood sugar for a week, like we normally do.
Plug it into the hearing aid.
If during that week you're not having any drop,
I don't have that
in your blood
capacity
sugar.
with these hearing aids.
Are you guys hearing me?
Put your phone on mute, please.
Yeah, so what I was saying is that what we'll do is we will check their blood sugars for a week. And if they're really not dropping and not showing any variability, and they don't usually test their blood sugars at home, then we don't test them unless they're symptomatic.
Okay.
But we will test them for a week just to show to ourselves that they're not really doing anything.
Okay, perfect. Thank you so much. That was absolutely wonderful. Any other quick questions, or you can email Dr. Wong?
This is Frank from Duke. I do have a question for you.
Yep.
Can you hear me?
Yes.
Yep.
Okay, so we tried the Dexcom device. The connectivity was the issue that I saw that we had with it on a patient, actually. And they were near the porthole. We thought we had good Bluetooth connection, and the patient's numbers were accurate initially. We double-checked them with our glucometer, which I agree with you about determining which glucometer you have is important. And we tracked their blood glucose before we put them in, obviously, into the chamber. But the connectivity about every 5 minutes checking them was the issue. It didn't seem to connect correctly, and the patient had symptoms. But when the patient came out, we weren't even, I thought the system via the Bluetooth was able to backlog their sugars, but it didn't seem to do that. So I don't know if that was just a mechanical issue with it. And they also said about the cost related to the Dexcom as being an issue, because every time you have to replace them, usually, I don't know if it's an out-of-pocket expense for the patient to do that, if it's not clinically indicated, because they change, correct me if I'm wrong, I think it's a week, they change it every week.
10 days. The
10
transmitters
days, okay.
are supposed to be replaced every 10 days. The issue is so the transmitters are supposed to have a 3-hour buffer. And so you could be disconnected for 3 hours, and then once you pair it with your receiving device, it's supposed to backlog everything. So if it didn't do that, it's an individual malfunction. But the design of the Dexcom is to allow that to do that. So yeah, and it kind of shoots the argument that you can monitor them in real time in the chamber, but you don't have to take the Dexcom off. And that's what we were initially doing, is we were removing it, and then we actually had a patient, we were taking it off and putting it back on every day, and they was like, well, you're not supposed to do that. And it's like, well, we did. But it was inaccurate because it takes 2 hours after you implant it for it to calibrate itself. So the Dexcom is self-calibrating, as opposed to the Libre, which is another model out there that's much more prevalent. It doesn't have continuous transmission. You have to take your receiver and wave it within like a couple of inches of the transmitter. So that's not effective in a multiplace. I don't know whether that would be effective in a monoplace or not.
Yeah, well, that was a concern. You're like, is it depend on the hole size of the multiplace? How thick the hole is will determine if it's going to connect correctly or not. I mean, that's why I was just wondering. I appreciate that answer. Thank you.
Yeah.
Okay, anything else? All right, thank you so much, Dr. Wong, and we will move on